Okay, welcome once again to X-Ray Ed's X-Ray Education. Okay, so today, I don't know if y'all can see me too good here or not, but maybe you can hear me and that's fine. Okay, so today we're going to go through X-Ray Ed's trash can of film, and we're going to take a look and we're going to see some chest X-rays. That's what we're going to be looking at today. We're going to see some X-rays and look at why the X-ray is not good and what needs to be changed when we go back to repeat that X-ray. Okay, so first up we have a pretty standard chest X-ray, probably a male patient. Whoever shot this X-ray decided that the thing to do was to put the cassette in sideways, which is no problem at all. But remember, when you're gonna line up on a male patient, it's really imperative that you feel for that inferior angle of the scapula so that you can locate where T7 is and then go up from that just a skosh, right? Not too much. In this case, what the technologist did, either they didn't feel for the patient's anatomy at all, or the patient had really thick shoulder muscles. Okay, and so what they did was they tried to put the top of the film at the top of the patient's shoulder. Well, that puts them way high, and look what happened. They cut off the costophrenic angles pretty significantly and included part of the patient's skull in the image. So that's no good. Other than that, was the technique okay? Well, okay, it's not perfect, but then again, with film, it's really hard to get it exact. But if we take a look, we can see the lung markings, and this is important. If you look at the spine, you can see vertebral bodies through the heart shadow. That means that your penetration was sufficient. So the technique was fine. We were just way mispositioned on this image. Let's take a look at image number 2. Okay. Could have been a female patient, could have been a slightly built male, not sure. What happened here? Well, I think that what they were trying to do was take an oblique image of the chest. When you do that, you just have to make sure you recenter so that your image is centered correctly and you don't wind up with this kind of nonsense. See, we've got almost a complete humerus X-ray on the right, but then the left lung field is cut off. And in as much as if this was PA, then this patient was swung slightly RAO, so the left lung field would have been the lung field of interest. It's cut off, needs to be repeated. Now, how's our technique? Okay, see right down through here, this is all whited out. We don't have sufficient penetration through the bottom part of the lungs here. Okay, this inferior anatomy is all whited out. We need to go back and try this again using some higher KVP and putting our patient correctly in front of the image receptor. All right, here's a neat one. Okay, what's wrong with that image? Well, a couple things. Are we aimed for T7? No, we're aimed for like T10 or something. We're way down here. Again, what'd somebody do? This is a small patient, and they put him in front of the image receptor, and they tried to line up the image receptor with the top of the patient's shoulders. In this case, a fairly small lady. What we could have done, if we would have felt for her scapula, we would have figured out that it was right about there. And okay, granted, her arms are up a little more than they should be. So T7 is, let's see, let's just count. 1, 2, 3, 4, 5, 6, 7. Okay, so T7, halfway through the lung field, is about right there. So what we could have done is we could have centered up a little bit better, and then we could have coned down. Because look, okay, this is what a friend of mine calls a chabdomen. Now, this is a combination of a chest and an abdomen where you just didn't bother to collimate at all. But this is kind of cool. See these little white things right here? Those are staples. This patient had their gallbladder taken out at some point in time. But anyway, okay, why could we have passed this image? Would we have gotten away with it? Well, can we see the vertebral bodies through the heart shadow? Yes. So technique was good. We can see lung markings. That's no problem. Hey, what the hey is this thing right here? Well, this patient had a really nice necklace on, We probably should have noticed that and taken the necklace off first, because this necklace is down in the lung field. We got to repeat this image. That's an artifact, and the doctor's not going to like it. So when we go and repeat this image, what are we going to do? Get the patient to relax their shoulders down. Okay, we're going to actually palpate their anatomy, and we're going to try to find T7 and make that our aiming point. We're going to use the same technique again because this technique worked the first time, but we're going to collimate down some because this patient's lungs aren't all that big. Okay, one more, and then we'll call it a day. Okay, what about this image here? Okay, this is a little tiny, we call it a fingernail artifact. It's actually from where the film got creased during handling, while it was going through the processor or something like that. And it looks like a fingernail mark, but it's not. But sometimes you'll see this on old films. So what do we do here? Okay, is this patient all on here? Why, yes, they are. Okay, we've got the apices are demonstrated. The costophrenic and cardiophrenic angles are demonstrated. We have sufficient penetration through the mediastinum for the most part. Did we burn any of it out? No, it doesn't look like it. Okay, so why was this image repeated? I'm not 100% sure. The only thing I can think of is the technologist looked at this image and decided that they did not have sufficient penetration through the bottom of the lungs, and so they decided they would go back and adjust their technique and reshoot. But positioning wise, this is fine, and I'll show you why. This is how I do just a basic, quick and dirty image critique on a chest x-ray. Number one, are the apices on there? Can I see the first rib? Why, yes, I can. T1 is on there. Okay, I've got all the apices demonstrated. Looking down the side, okay, can I see all the lung markings on both sides? Yes, I can. Do I have the costophrenic angles on there? Yes, I do. Okay, now that I'm up here and I'm looking really, really closely, I can see that there is quantum model here in these lung bases. So we did not have sufficient, we probably did need a little bit more KVP. Okay, you can kind of see, and this is another part of your critique, costophrenic angles, cardiophrenic angles. In other words, we've got the whole hemidiaphragm left and right on both sides. Okay, can we see through the heart shadow? We have to be able to see these vertebral bodies through the heart shadow. And in this area right here, it is very grainy. It's underpenetrated. We need to go back. We need to hit that thing with some higher KVP. Probably not any more mass. And I'll tell you why. If you leave your KVP alone and you just increase your mass, the only thing you're going to do is make these dark areas darker. These light areas that weren't sufficiently penetrated, they're still not going to be sufficiently penetrated. In order to get through here and actually demonstrate this anatomy, you need higher KVP. Okay. All right, so that basically, and are we centered at T7? Yeah, approximately. Right here's the inferior angle of the scapula, so that's going to put us at T7, T8. So our centering is good. We could have collimated top and bottom. We could have collimated a little bit side to side. This is almost certainly, yes, see the breast shadows here. This is a female patient. So we could have coned down some, but other than that, our technique was what caused us to have to repeat this. All right, so that's my quick little analysis of some x-rays. What you want to do when you're analyzing your x-rays, you want to look and see, okay, is the anatomy all on there? Yes. Is my technique sufficient? Did I penetrate the heart shadow? Yes. Are there any artifacts on there? No. Is it correctly marked? Yes. Okay, so it's good to go. If our technique had been okay, then this would have been fine. All right, so hopefully that helps people a little bit whenever you're looking at your images. Rotation, you can look at these sternoclavicular joints here. Those are about equidistant from the center of the spine, so we didn't have too much rotation. Clavicles, relatively flat, so the patient's shoulders were relaxed down like they're supposed to be. Yeah, the only real reason to repeat this is just for the technique in this particular case. All right, so yeah, I'm going to wrap up here for today. We're going to come back and we're going to talk some more about x-rays later, but for the time being, this is X-Ray Ed. Peace out. Get out there and take good care of your patients. Take some good x-rays. If you like us, please like and subscribe. If you have any questions about any of these radiographs or how to tell if you've got a good radiograph or not, please just comment down below and we'll try to get back with you and answer as best we can. All right, thanks a bunch for tuning in and have a great day.